Well, welcome everybody to the public session of the NHS England and NHS Improvement Board. I've got apologies from Dido and from Jeremy Townsend. Dido is taking a leave of absence for 6 months from being chair of NHS Improvement, so she can focus her whole time on test and trace and on the National Institute for Public Protection. And Andrew Morris, who everybody knows, is stepping up to take her place as acting chair of NHS Improvement.
David Roberts, I wonder, do you want to step in while David P reconnects?
Fine, thank you. People can hear me, I hope. So Andrew Morris has taken over as as the interim chair of NHS Improvement, and Andrew, thank you for that. Maybe if we could turn straight away then please to the declarations of interest. I don't believe there are any that are not on the register, but can I just confirm that? Thank you. And then we have the minutes of the meeting held on the 1st of October. Can we take those as a fair reflection? Yeah, thank you very much. In which case, Simon, over to you for your Chief Executive's report.
Okay, thank you very much, David. So let me just start with an update on the coronavirus situation. Over the last week, we've seen, fortunately, the number of COVID positive patients in hospital beginning to stabilise, plateau at about the 14,500 number. Of course, that compares with under 500 at the beginning of September. And the geographical composition of that inpatient count is changing. So we're seeing pleasing reductions in parts of the northwest, places like Liverpool, but we are seeing some continuing increases in parts of the Midlands and particularly places such as East Kent. So that has all served to underline the value of the local escalation processes which we are using to make almost real-time judgments about the mix of health services that can be provided in each area. And as a consequence of that, we are, across the service as a whole, able to look after far more patients while managing nearly 15,000 COVID patients than was the case back in March or April. So in fact, as of today, we've got 20,000 more emergency inpatients other than COVID patients than we had at the time when we last had 15,000 COVID inpatients. We've got 3 times more overnight elective beds in use for routine operations, and we've got cancer treatments and GP appointments mostly now back to usual levels. But it does mean that we've got to ensure that in the weeks leading up to Christmas, the number of COVID inpatients overall continues hopefully to come down in anticipation of further seasonal winter pressures that you'd normally expect in January and February, and just given the risks of a possible third COVID wave. So the approach that we are taking, we will have a chance to discuss further with Pauline and Amanda later on in the agenda, but I think it is obviously right to say, as we usually do, a huge thank you to all of our colleagues across the health service who have been in many places in the eye of a storm that has been greater than the storm that they faced first time round in the first wave of COVID. And of course, this is unfortunately has been a shared experience with hospitals across Europe, which have also been filling up over the last 2 months. And that is as true in France and Germany and the Netherlands and Belgium and Switzerland as it is here in England and the rest of the United Kingdom. We have had positive signals from 3 vaccine consortia over recent days, as you know, and our work to mobilise readiness for delivery beginning on day 1 of availability is well advanced. The bulk of the vaccinations for at-risk groups, as the Health Secretary set out, will inevitably take place in January, March, April timeframe based on the supply schedules that we're expecting from the producers of the flu vaccinations. But we do expect to be able to make a strong start this side of Christmas, subject to the independent regulators' licensing decisions. And then I think the final thing I would say, just by way of introduction, is that, of course, yesterday was the government's spending review. We have, right from the start of this process, of course, recognised that we already have a multi-year revenue funding deal linked to the long-term plan. So we're not looking to reopen that in its own terms. But given the pandemic, 2 things have obviously changed, one of which being the extra costs of providing care linked to COVID itself. And we've had financial support for that during the course of this year. And our agreement with government is that we will continue to do so going into next year. And early in the new year, we'll take stock of what those costs are likely to be. So in the meantime, systems, trusts should continue to plan on the basis that they will sustain the capacity and the staffing that they have available to them now. And of course, the other thing that's changed, as well as COVID costs, and by the way, COVID costs relating to PPE and to test and trace are funded direct by the Department of Health and Social Care, given that those are not routed financially or operationally through NHS England and NHS Improvement. But as well as the COVID costs, there are increasing health needs in other areas, whether that's the backlog for diagnostics and routine procedures, or increasing evidence of the intensification of need for mental health services. And so we were therefore, we welcome the fact that the Chancellor has made available additional revenue, £1.5 billion of additional revenue for those extra health needs going into next year. We will be working, I'll be working closely with Claire Murdoch and colleagues in the mental health sector to identify the right priorities for that additional £500 million of mental health spending, which will be on top of the already planned increases in mental health services next year. And as part of that, we'll be making the connection across to the workforce growth that we need, particularly sourced through Health Education England. 2 other final points on the spending review. We were successful in securing £325 million of additional capital investment for diagnostics, which should enable us to make a start on implementing the Mike Richards diagnostic review that this board discussed, I think, at our last public meeting. And in addition, pleased to see a continuation now for the additional financial support for hospices, which was so important to us in the first half of this year during wave 1 of COVID. So why don't I stop there, see if there are any points immediately arising. Otherwise, a number of those themes will be referred to during the rest of the discussion.
Thank you, Simon, and sorry for the glitch on my technology at the beginning of the meeting. Simon, you went down to UCLH a couple of weeks ago to look at what they're doing on long COVID, treating patients with long COVID symptoms. Anything you can say about how we're going to look after those patients going forwards?
Yes, thank you, David. Well, it is, I think, now beyond doubt that this condition called long COVID does exist and does affect a small but significant minority of people who have had COVID, not necessarily those who were hospitalized, let alone those who actually had a positive COVID test early on in the pandemic. And so with NICE, we have worked to establish a case definition to properly define what this group of patients and condition looks like, and now the care pathways that are likely to be appropriate. We've allocated an additional £10 million for the balance of the year to support the creation of some of the long COVID clinics that are coming together in different parts of the country. And Ian Dodge is actually going to be overseeing the rollout of these long COVID services, which will, in some cases, be driven off what's happening in primary and community services with the interface with specialist care. In others, it is groups of specialists in outpatients who've essentially come together in their area to create these services. I don't know if Ian wants to add to that.
The first of those clinics have already gone live, Simon, and we are expecting an initial and comprehensive network to roll out during December and the new year, along with the go live of the Your Recovery website, particularly focused on pulmonary rehabilitation. And there will be a lot of further work, including on research and the embedding of the pathways within primary and community, as well as specialist services. And I look forward to coming back to the board to update colleagues on further progress in the new year.
Thanks, Ian. Any other questions for Simon, or we should move over to Amanda on the operations side? Amanda and Pauline?
Thank you, David. And thank you, Simon, for your very comprehensive introduction, because I think that is really important that in introducing this paper, which is about the kind of operational performance, which covers COVID, winter, elective, it is absolutely in the context that Simon's just set out about the fact that we have had now for some time a really very significant number of patients with COVID in our hospitals, as he said, around sort of 14,500. And I think he is right to highlight that actually the way that the NHS has worked in partnership as through the first wave, so that is absolutely a local level, pulling in voluntary sector partners, patients themselves, working very closely with local government to provide mutual aid to ensure that services can be maintained wherever possible to support staff, has really made a difference through this second wave, absolutely as it did in the first. So lots of things to talk about in that, but the things that, if I may, I'd just like to draw attention to, I think, are firstly, the importance of the support for our staff through this, not just second wave, but as we look forward for the next few months. Been a huge amount of work nationally, but also a huge amount of work locally to put together packages of support for people who are absolutely, as Simon says, in the eye of the storm and continue to be, and have relentlessly been now for some considerable period of time. So the importance of putting care for our staff at the heart of our response, alongside, of course, care for our patients, I think never been more important. Secondly, I think it's just worth saying that exactly as Simon's called out, we have maintained through this second wave the level of non-COVID care, particularly I'm thinking here elective care, that we had managed to collectively achieve as we headed in to the second wave. So rather than that significant reduction in activity that we saw in the first wave, we've absolutely been able to maintain that focus on elective care as well. So that is I think a huge testament actually to the commitment of colleagues across the NHS who have made it possible and made it their business to work together to try and make sure that everyone who needed to be seen could be seen over the last few months. So what does that mean in practice? It means, and the paper calls this out, it means that we have managed to improve and increase use of the independent sector. It means that if we're thinking about things that are of a particular concern, I know, to the board, so things like cancer care, it means that treatment levels, both 2-week wait and treatment levels, back to pre-COVID levels. It means a huge amount of work done now around clinical validation. It's been done on the waiting list, moving on now to diagnostics. And that's really about making sure that individual patients have confirmed their preference for treatment, and that there is improved communication then between the caregiver, the patient, their GP, their carer, about what the plan is, what's going to happen to them. So something that we've heard very clearly fed back to us from patient groups that was important to them, as well as being important to us to run services well. It also means, again, real credit to Pauline and her team on this, a hugely rapid rollout, thanks to the availability of tests from Test and Trace now, of lateral flow testing across the NHS, so that asymptomatic staff can be tested regularly. I'll let Pauline talk more about that, but 25 million tests that have gone out over the last 10 days or so, to mean that we're in a very different position in terms of protecting our staff, protecting our patients, than we have that opportunity now that we didn't before. Other things it means that on urgent emergency care, we are able, I think now, and again, Pauline will talk more about this, to be quite confident about the rollout of 111 first, beyond the 16 sites that have already implemented that. So December, that's going to be a major focus. Clearly, we've also got a major programme of capital development in place in A&E. However, I think it is worth saying, and the board will be cited on this already, I know, that as you would expect at this time of year, there is more pressure on the urgent emergency care pathway, and we are particularly concerned about avoiding crowding in A&E departments. We would be anyway, but when you add the COVID risk into the picture, it becomes particularly important for us to find those alternative ways to provide care for our patients. So 111 being a particularly good example of that, so that people can get the care they need, but without needing to present it at the front door. And also that, of course, we're then managing flow through our hospitals, and therefore the important role, of course, our community colleagues play, social care, in helping patients safely discharge from hospital, so that we're not seeing that pressure build up at the front door. Again, Pauline will want to say more about that. Final couple of things to mention, and I think it probably should have started rather than ended here, but we all know what an important role primary care has played, GPs and their colleagues, over, again, this whole year, and now activity in primary care back again to pre-COVID levels, and we should, I think, also just recognise the particularly important role, not just in things like long COVID that Ian's already mentioned and the rollout of the COVID home oximetry services that's happening now, but also the important role they play in supporting the clinically extremely vulnerable patients, and that's a group who, again, primary care have a particularly important role, and particularly, we've relied on them heavily this year to continue to do that. Final point, Simon's just made it, but we are, and again, I know the board's very alert to this, but we are seeing significant increase in demand for mental health services, and that's, again, particularly in the acute presentation. So the very welcome additional funding for mental health will certainly make a difference as we look to the future, but right now a big focus not just on delivering those long-term plan commitments, but also in orientating the work of the mental health team around things like the crisis helplines, the digital access to care, in addition to the face-to-face routes, to make sure that the COVID specific needs are being addressed. So I know that's a quick run through, but I hope that's okay in terms of picking up COVID, a bit of where we are in urgent emergency care, some of the risks, but also where we are on the elective side of our responsibilities. But let me hand over to Pauline to pick up.
Thank you, Amanda. And I don't want to repeat anything that Amanda or Simon have already covered. So I think just for me to start off by acknowledging the amazing work that our staff are doing in all areas of care. I think wave 2 has been significantly different to wave 1 insofar as people have had to deal with 3 challenges. Our staff have had to deal with 3 challenges, caring for our COVID patients, as Amanda described, but also during wave 2, there has been a major focus on being able to continue our elective work. And clearly, because of the timing of wave 2, we are in the winter season and seeing pressures in our emergency services. So if you just look at what's happening in our emergency departments, activity, attendances are up 68% on what we were seeing last April, and admissions are up 42%. So I think that gives you a sense of how different it is at this point of the year. But performance continues to be better than it was this time last year. Amanda made some references to 111 and the rollout of 111 First during the month of December, and we have now been able to work with all of our 111 providers, all of our systems throughout the country, to reach assurance that they have the services in place to support that rollout. And at the moment, our core 111 services are actually dealing with an 18.8% increase in calls and doing that very well. And they're managing to maintain very good call answering standards and also really good standards with regards to clinical input into calls. Just staying on the theme of emergency care for a minute, our ambulance services was seeing increases in demand through the work that they're doing on See and Treat and Hear and Treat pilots. They're able to reduce the number of conveyances to our emergency departments. So basically able to find other pathways for patients to avoid them needing to be brought in to departments. Moving on to maybe the last area that I wanted to mention for UEC, and that's our urgent treatment centres, and they will play a really significant role as we roll out 111 First. And we have now got 178 UTCs designated and 36 more to go by the end of this year. Just turning back to elective care, with regards to the work that's been done, we've been able to maintain a waiting list that's smaller than the waiting list we had this time last year. Now, clearly, some of that is down to reduced demand, but I think it's also down to increased activity and people being able to bring work back on that they weren't able to do earlier in the year, and using a number of different ways to do that, coming up with very different ways of providing care through the adapt and adopt work, establishing things like elective care hubs, having a real focus on diagnostic work. At the moment, we are doing 88% of last year's activity, which I think is pretty phenomenal. And looking at different technologies, different pathways, using the capital, the 150 million that was put into the system for that. One other thing just to mention is IS. Amanda mentioned the fact that we are having an increasing use of the independent sector and working on a daily basis with our colleagues to ensure that patients get seen in the appropriate settings in the appropriate time spans. And finally, to finish where Amanda started on supporting our staff, yes, we are rolling out testing, lateral flow testing. All of our staff will have the opportunity to administer their own test twice a week. And if the test says that they're positive, they will then go for PCR testing. And we've been able to roll out 25 million of these test kits to date to our acute services, our mental health services, our core community services, and we hope to be able to continue into primary care, community interest companies, and indeed some visitors later this week and into next week. And then finally, I think the other area where we're very keen to support our staff in advance of any COVID vaccine is with the winter flu vaccine, and working very hard to get the best possible coverage across our services. Thank you.
Thank you very much for that, Amanda and Pauline. Ian Dodge.
Thank you. I just wanted to come in briefly to amplify some of Amanda's comments on the role of primary care. It's been an immense achievement to have recovered back to pre-COVID levels. We have by far the most successful winter flu program, led primarily by general practice. We are successfully hiring lots of additional staff under the additional role scheme. General practice has also shown a really strong response to the COVID vaccination programme, and we've put in £150 million actually to further expand capacity. So I think really worth recognising the immensity of that contribution and our appreciation.
Thanks, Ian. Whoa.
Thank you, David. Amanda, thanks for your very fulsome report. I wonder if it's just worth expanding a little bit on the building works and the connection with infection prevention and control, making sure that the patient journey in that part of our activities is very safe.
Thank you, Wal. I'll let Pauline perhaps just talk about a bit more of the detail of what's going on, but I think your kind of headline point is a really important one, because of course what the NHS has done over the course of the past year is really reorganise how it works into different pathways to keep those kind of COVID secure pathways separate from those pathways where patients are either diagnosed as COVID positive or there's a risk. And what that has meant is substantial changes to the way that the estate is used, as well as how staff are deployed. So a really, really kind of significant programme of work as a consequence of COVID coming whenever it was, February time, March time of last year. And what we're now seeing, what we're able to do with the capital investment is begin to make the additional changes so that actually we're in a more secure environment, more resilient going forward. But Pauline, perhaps you could just pick up the detail.
Yes, just to maybe mention three areas. As far as emergency care is concerned, the first two, we've got 25 major schemes in emergency departments. So that's really schemes that are allowing those departments to redesign, to reprofile their departments for this winter to make sure that they're safe while we still have COVID in the system, but also to make significant changes for the future delivery of emergency care. At the same time, the second scheme, the first set of schemes comes to 150 million. The second group of projects comes to 300 million, and that basically covers just about every emergency department that we have. And again, it's allowing them to focus on how they have needed to redesign their department to make them safe during the COVID period, but also to make changes that are going to be really valuable from an infection control point of view and from a flow point of view moving forward post-COVID. I think just the third area to mention, which I referred to earlier, is that it may not be capital schemes per se, but we have invested 150 million in diagnostic equipment and some changes to facilitate the diagnostic equipment. And that was coming out of wave one of COVID and realising and appreciating the work that we were going to need to do to catch up on some of the work that we hadn't been able to do to the numbers that we would have liked in the earlier part of the year.
Thank you, Lynn. David Roberts.
Amanda, Pauline, thank you. I'm interested in the where we've got to with NHS 111 first, and in particular, I'd be interested to hear how what has been the reaction, what's been the changes in and improvements in operation as a consequence of bringing it in, what's been the reaction of clinicians, and critically, what's been the reaction of patients?
Shall I ask that, Amanda? Okay, so basically 111 first. Well, basically what 111 first is aiming to do is to encourage people that when they feel they have an urgent or emergency care need, to go online or actually call 111 to get advice. And by being able to do that, then we can support the caller to get the best possible pathway. And that might mean asking somebody to go to a pharmacy. It might mean asking somebody or linking somebody up with a pathway of care that they're already receiving. Or it might mean that somebody needs to go to an emergency department. The significant difference under 111 First is that for people who do need care in an emergency department, we will be able to book them in. And clearly it will depend on the availability of having sufficient booking slots, etc., which we absolutely have been working on to ensure that that will be there, and that we have the staffing available to support this type of model. And so the work that we've done in the last 6 months, last 6 to 9 months, is to prepare not only the 111 services for the development of it, but all of the pathways of care, all of the directories of services that will support the model. And as I referred to earlier, David, we've gone through a fairly systematic exercise in making sure that the staff exist, the call pathways have been redesigned, etc. The directory of services is able to support it as we roll it out in different parts of the country. As Amanda referred to earlier, we've had a number of what we call first mover sites, and we have learned from those as to what's necessary to ensure that we meet the needs of our patients and the response of our clinicians. So we've listened to feedback from patients, and we've listened to feedback from our clinicians, and we have designed as the days and weeks have gone by. I think it's fair to say that working with those 18 first movers, they have found this to be a very good experience, but I think they're all pushing us at this stage to go a little step further and to be able to put more comms into the system, because I think local comms in this day and age achieve so much, but national comms obviously is able to get our message across in a slightly stronger way. So what we will do early in December is to start rolling that out in a measured way.
And given how sensitive, Pauline, what's the average call wait time for NHS 111 First?
I have that written down in front of me, and I'm going to have to come back to you.
We haven't even rehearsed the question.
But I definitely have that piece of information.
Okay, don't worry. Come back to me later. Come back to me later.
But can I say that we have returned to our call answering times from earlier in the year? And clearly we had some problems at the very start of the COVID period, but we're back to our really good performance. I'll get you the number in a second.
If it comes to you later on, just fill us in, Pauline. But Ara, you got a question?
Thank you, Chair. Well, I think firstly I'd like to, me as a clinician working here at St Mary's, just to thank Amanda and Simon and the whole team for really transforming my life from wave one, where I found myself unemployed, into actually starting to operate with all the guidance and support they have given us at a local level. So thank you for that. On the other hand, I wanted to ask a question. What are our plans in many, many good learning lessons that we've had during COVID that we can maintain as we see ourselves through this dreadful disease post-COVID, which we have to retain, because I think we've seen the best in our NHS staff during COVID. We have to retain that somehow. Thank you.
Amanda, I think that's probably for you.
Well, I'm happy to start, but I suspect this might be something that certainly Steve and Ruth might want to come in on as well, because I think, and thank you for what you've just said, Ara, but I think actually we should probably say thank you for all that you do. And of course, as colleagues have said, for all of our clinical colleagues across the country, because I mean, our job is entirely to try and make life as easy as possible for people to do their jobs. So what do we need to hold on to? Actually, I think I'd probably start with clinical leadership. So my sense through the first wave, and I think it's been true through the second as well, is that what we have really seen is multidisciplinary clinical leadership really helping to identify whether that's through critical care networks or it's down to that local place, working out what their population needs and organising services around that. That's one of the things we must not lose sight of as a kind of clear benefit that we need to build on and go forward with. And when we talk about the ICSs later, hopefully some of that will come through. I think clearly there's a huge opportunity for us to build on what's happened through the use of technology in the last few months, I think we've seen the importance of introducing digital alongside and in the right way, so that for patients it becomes something that's really empowering, and it's not about finding ways to force people into new ways of working if they're not comfortable with it, but it is absolutely about offering people different and in many cases better ways of accessing services that are more convenient, that are around actually what they need from us, rather than a more traditional face-to-face model, which isn't always the best way. And I think we've really shown that we need to build on that as we go forward. I think there's also something for me about, and London is certainly at the vanguard of this, really looking at how we organise services most efficiently. So that is, when I say efficiently, I do mean in a sense that is both about value for money, but also about quality outcomes. So what we've seen, I think, in the way that London has responded, clinically led response to the pandemic, has been about trying to say, how do we get now some real momentum behind high quality, consistent pathways of care, which do mean in some cases organising services so that higher volumes of activity are going through certain sites, and that's driving both better outcomes, better patient experience, and also better value. So I think those are the sorts of ideas that certainly London has been at the vanguard at, but there are examples of that across the country where I know that colleagues are equally keen to kind of to build on the work from that they've done so far and keep going with it. The final one I'd call out, but I will let Steve and Ruth come in, is I do think for me it is this final point about how do we really get serious about the support for the health and well-being of our staff. There's been so much emphasis, and rightly so, on that over the past year, but it's knitted absolutely fundamentally with the equality, diversity and inclusion agenda. So making a serious leadership commitment to that not just being a pandemic response, but being about, as the people plan sets out, a way that we are committed to working for the long term, I think would be the other area that feels to me to be just a very obvious one to call out at this point. But look, that's top of mind stuff. I'm sure Steve and Ruth will have other things to add.
Steve, do you want to? Because Ruth's going to ask another question anyway, I think. But Steve, have you got any reflections?
Well, to be honest, I think Amanda's probably given almost all the examples I would have given. So she's sort of done the job for me. And I agree completely with her analysis. And there are lots of other examples at a sort of more nuanced level than the more system-wide examples perhaps Amanda's given. The only other comment I'd add is, which is related, is when we look back to the long-term plan, our 10-year strategy. For me, the pandemic has really highlighted the need to just continue with the key priorities in the long-term plan. I think almost all the things that we wanted to focus on, Amanda's mentioned digital transformation as one, but the inequalities agenda, the prevention agenda, are all things that I think COVID has brought sharply into focus. And I personally, and I'm sure as a board, it's just given us more determination to go harder and faster with that strategy as much as we possibly can.
Thanks, Steve. Pauline, have you just found the answer to David Roberts' question, I think, have you?
Yes, I knew I had it written in front of me this morning. 79.1% of our calls are answered within 60 seconds, David. So that really takes us back to the really excellent performance we had earlier in the year.
Thanks, Pauline. So, Ruth.
Thank you very much. I'll go back into what Amanda and Steve and Ara was talking about. So for me, there's been several bits of learning, which has been an amazing flexibility of our staff and their willingness to do additional training, whether that's those people stepping into critical care units, whether those people stepping in to work with our homeless people or into the community. People have gone and been very, very flexible, come out of their normal area of expertise and really have taken on extra training, taken on extra responsibility. And that has been something of great source of pride to me about how people have done that. The big one as well for me is about lesson learnt is around how local implementation plans are so much more important. We can say things nationally, we can say and we can plan and policy drivers, but actually, unless it's backed by local implementation plans, we don't get the same success as we could have. So that's a big lesson for me. Around infection prevention control, those places have got more single rooms, have greater achievement of maintaining excellence in infection control. And of course, I've been so impressed by the way over 20,000 student nurses and midwives joined the front line in wave 1, and how people did go over and above, retained their, delayed their retirement, worked extra hours. And I think our big challenge going forward is how we not just continue to recruit people like that, but how we retain them. And that's why later on today we're discussing health and wellbeing, which is going to be an important plank. And my only other point, David, which is why my hand was originally up, was to go back to Amanda and Pauline's conversation about just how much work is going through the NHS right now, not just patients with COVID, but also, of course, those patients are coming in through the urgent care pathway like they didn't in so many ways before, and indeed doing elective care. And I've been to some places recently that are very, very proud of what they're doing on their elective care pathways as well as their emergency pathways. And I just want to say a big thank you to all of our staff. Our clinicians get a thank you lots of the times, but I just wanted to call out all of our staff, whether they're our portering staff, our cleaning staff, to our patient journeys. And I just want to say thank you to all of our staff across health and social care. Thank you, David.
Thanks very much, Ruth. Well, can we move on to the finances, Julian? Would you like to tell us where we are?
So in the note, in the paper that's come around the board, I mean, it basically shows the position to the end of September, which I just note is the last month for the kind of retrospective claim process for extra COVID costs we had in place. It broadly shows that actually the aggregate level of spend has remained remarkably consistent over those first 6 months. Worth noting, though, that in September, the kind of COVID costs have continued to come down, but the marginal cost of, in particular, all the extra activity we have put through the acute sector, which Amanda and Pauline have been talking about, does show that cost ramping up. Now, for the second half of the year, we have given to the NHS financial envelopes for them to live within, and that put more money into the NHS. I mean, to reflect the fact that we were asking for that sort of acute activity to continue to step back up. And with the planning returns we've had back, and with October's data, which I did a first review of yesterday, you know, I still feel comfortable that the envelopes we've got are sufficient to allow the recovery of activity, even as we have seen some of the, well, even as we've gone through in October, the kind of the first signs of the second wave we've definitely lived through in November. On capital, anticipating the normal pretty steep sort of hockey stick angle as we get into the final quarter of the year, reflecting the money in particular we've put out there for increasing A&E capacity, catching up with some of the critical infrastructure, beginning the work to get rid of mental health dormitories. Whereas I think probably Simon said earlier, we've had the second year's funding for that programme guaranteed in the SR announced earlier this week. And I think Simon's already covered the points on the spending review. Happy to take any questions.
Just one point on the spending review. I mean, Simon did mention it, but the 330 million, I think, that's been earmarked for diagnostics, which we discussed at the last board meeting in the light of Mike Richards' report. I mean, how do you see that playing out over the next couple of years, Julian?
So, look, I mean, first of all, I'd say it's a positive sign that the government have committed more funding to it so we can get going. And we will need to have a conversation in the round about what we can do on that programme and actually how it fits with some of the additional investment in technology that has also been identified. So we work out across the piece what the priorities are for investment in the NHS. And I think we just now need to plan and be clear with government. We're planning on a multi-year programme, because that's now the only sensible way in which we can work out, what are the first steps that we should take this year to realising the vision set out in Mike's report. And I think they've at least acknowledged, at least in the conversations we've had, they recognise this is the beginning of a multi-year programme. Clearly, we'll have to wait till another spending review, no doubt, sometime next summer.
So, I mean, Laura, looking at Laura Wade-Geary now, just in terms of the future, getting the digital transformation through the NHS is going to be so important to getting improvements in both quality of care and in sort of better value, if you like. I mean, how do you see digital going forwards, Laura, as part of this capital programme?
Well, I think Julian has probably put his finger on it, in the sense that I think what will really help is when we look at the funding in the round and examine how we build digital into that to maximise the impact of our spend, because I think we need to judge both the short and the long term in here, and as a number of people have talked about, what's been achieved during COVID in terms of the sort of shortening of lines of command and things being able to be achieved more quickly. That's the kind of thing we've got to hang on to as we develop digitally enabled solutions. But I think that you're right that playing the capital into this is going to be key.
Thanks, Laura. And of course, innovation is going to be crucial to our future as well, which sort of leads us on to the next item. And I see Emily has stepped up to join us again, who has executive sort of director line management for the Accelerated Access Collaborative. But I wonder, Ara, did you want to just introduce this next section? Is Matt Whitty here? Is he here now? I know we're 5 minutes ahead.
Yes,
yes, okay. Did you just want to sort of sketch out a little bit of background, Ara, first?
Thank you. So thank you very much, Chair. I think everyone in the room will know, including being in public board. I'll give you a little bit of summary of what the Accelerated Access Collaborative is. An attempt by government by bringing a number of stakeholders involved in innovation. Obviously, NHS England being the commissioners, NHSI being the providers of care, and obviously NICE, the regulator, MHRA, and obviously the public representatives, patient representative groups, and the National Institute of Clinical and Health Excellence. And it's a convening board really identifying the high impact innovations that have already had approval from NICE to accelerate their uptake across the NHS. And it's been active for the last 2 years. And we're delighted to have Matt Whitty with us, who's the current acting CEO of the AAC, who's going to present some of the outputs from the AAC over the last 18 months or so. And as we all know, AAC is hosted by NHS England. And I'm very grateful for all the executive teams that have provided us support for the success of the AAC. Thank you. I'll hand over to Matt.
Welcome, Matt. I've lost you again. Are you there, Matt?
Thanks, David, and thanks, Ara. And thank you all for your time this afternoon. I won't cover too much of the background, as I think Lord Darcy's covered that sufficiently, and most of it will be in the paper. Today, I really want to focus on the impact of our work in the first year of what was our expanded role of the Accelerated Access Collaborative. I'm going to talk a little bit about our support in responding to the COVID-19 pandemic. And then I'm going to briefly summarise where we're going next and ask for a steer on how best to involve you and your teams on that work. So I really wanted to start with the impacts of what it is the work has led to. So we've got a range of programmes that support ideas, and this is right from the research or early stage innovations right through to later stage proven or NICE approved innovations that are ready for widespread adoption in the NHS. And in 1920, around 750,000 patients benefited from our programmes. So you can really see the reach of what it is that we're achieving here. And I think that's really testament to all of the partners and the efforts that are from all of the colleagues that are involved in the AAC itself. Because of the programmes that we supported, patients spent over 100,000 fewer days in hospital. We supported over 2,700 individual innovations. Many of these were through our delivery partners in the academic health science networks, who are key partners in how we deliver a lot of these innovations and how we interface with NHS organisations at a local level. We supported a similar number of innovators, including 150 NHS staff as part of our Clinical Entrepreneurs Programme. And this is a programme that provides mentoring and guidance to NHS staff who have innovative ideas but need support in developing them. And they can get the mentoring they require in order to develop those ideas whilst remaining in the NHS. Our programme saved the NHS at least £50 million in 1920, and they also safeguarded or created over 1,000 jobs in the life sciences sector. I'd like to just dig a little deeper into a couple of the technologies that we supported as well. So firstly, placental growth factor based testing. So this is a NICE approved test that we supported, and we supported it through the Innovation and Technology Payment Programme. As I said, it's a NICE approved test and it rules out preeclampsia, which is a potentially life-threatening condition in pregnant women. So before our support, this diagnostic was available in only one hospital. And at the end of 1920, over 21,000 pregnant women in 60 hospitals across England had had access to that treatment. That's continued into this year, and we've had over 16,000 pregnant women and it's had access to it, and it's now in 86 sites in the first 6 months of this financial year. The second technology I wanted to briefly touch on is HeartFlow. So this is a NICE approved digital technology that provides information to clinicians on the flow of blood through the heart, and its use can help reduce the need for more invasive procedures. So there are now 50 trusts utilising this technology across England, and we're well ahead of European countries, and on a per capita basis we've got about 10 times greater uptake than the USA, which is where this technology originated from. So two really good examples of how the NHS can adopt innovation at scale through the support that we've been able to provide. Last year, we also launched the Artificial Intelligence in Health and Care Award, and this is a programme where we directly fund the most promising artificial intelligence technologies, and we evaluate them in NHS settings, and we're supporting 42 innovations across 70 sites in the UK. The second round is also open, so we're looking for more innovations that we can support, and that closes on the 8th of December. Secondly, I want to talk about our support during the COVID-19 pandemic. So one of the key things that we did was that we redeployed our Horizon scanning function. So this is our function where we're constantly looking for what are the new technologies, the new medicines that are coming through that are potentially useful. And we redeployed that function to work with others across NHS England and NHS Improvement, NICE, the Medicines and Healthcare Regulatory Agency and the National Institute for Health Research. And we created something called the Research to Access Pathway for Investigational Drugs in COVID-19, or Rapid C19. So this was a process that was running scans to undertake, looking across all the databases to see what are the potentially beneficial treatments that are coming through that could support the efforts for treating COVID. And this process supported remdesivir, dexamethasone and hydrocortisone being available on the NHS within hours of the study readouts. So that is really, really rapid compared to what the status quo would have been without that piece of work. So in terms of where we go next, before I move on to that, I just wanted to quickly touch on, just to highlight really that my team is really committed to supporting our Black, Asian and minority ethnic colleagues and our patients, and particularly following the realisation of the disproportionate impact of COVID-19. And we're also extremely mindful of the Black Lives Matter movement, and every individual in our team has taken an equality, diversity and inclusiveness objective, just to make sure that we are all doing what we can to help our efforts there. We're also looking at how that can impact on our programmes of work. So in the first instance, our NHS Clinical Entrepreneur Programme have co-developed a programme charter which places equality, diversity and inclusiveness principles at the core, and that'll underpin a range of activity that we take, and we really believe that that will actually strengthen the programme offering for all. And that programme is going to act as an exemplar about how we inform our future programmes and how we can embed that into our programmes to reduce health inequalities. Thinking about research, we've seen the impact, as I mentioned, for the COVID research. So we've seen world-class COVID research being undertaken in the NHS. And we've seen that not only improve patient outcomes here, but that's changed clinical pathways across the world. So I also wanted to thank the thousands of patients who put themselves forward for that research to help others. And we're working closely with colleagues in the Department of Health and Social Care, the National Institute for Health Research, to support the safe restart of non-COVID research as well, because that's going to be essential to answering the key questions for health in the coming years as well. And finally, I just wanted to quickly touch on an answer to the question that Lord Darzi posed about what we're doing about some of the changes that in practice that we've seen during COVID. So we're working really closely with Hugh Mackake's Beneficial Change Programme, the Department of Health and Social Care, and we're looking to understand what are the changes that have happened during COVID and how can we evaluate these. And we're doing two things. So firstly, we've got an engagement piece where we're looking to understand what those changes are, how we can prioritise them, and how we can evaluate them and understand which ones we keep. And secondly, we're looking at how we can link that into the existing research and innovation infrastructure. So this is not about inventing new parts of the structure that we can add to a already fairly complicated landscape. This is about how we can take the learnings from COVID, evaluate them thoroughly, and implement using the existing infrastructure. Finally, we'll use the outputs of that to help review our priorities, and we'll take that to the AAC board in 2021.
Thank you very much, Matt. That was a very good introduction. Munir, you've got a question.
Yes, thank you very much, Matt. Really great paper and really good to see the impact of the AAC. I wonder whether you can give a broad overview of what you see are the major challenges in terms of getting innovation into the NHS. Is it organizational? Is it behavioral? Is it funding? And what needs to be done to be able to upscale what you're doing in terms of improving the uptake of innovations?
Well, thank you very much. All of the above issues. So funding. So we've seen through our innovation and technology payment programme that actually where we centrally fund technologies that can help to support the uptake of those technologies, but it's certainly not the only answer. And even when we are directly funding technologies, they don't always get the uptake that we would like because of other factors. So a lot of it comes down to how strong the clinical case is. These things need to have clinical support, and we always encourage the innovators that we talk to engage with NICE at an early stage and to take their products through NICE in order to get that sort of robust clinical consensus. And it's much easier for NICE to have that consensus than it is for us to have those at a national level without the infrastructure that they've got there. I think secondly, there really needs to be a clear case that patients can benefit. I think we really need to do more to get that pull from patients. We want patients demanding these technologies in order to drive that culture change. And I think in terms of the culture change, I think there's a lot more that we can do to change the culture of innovation in the NHS. Probably the key thing that we see is where, and we saw this with a piece of work that we did with the Care Quality Commission, where we went round to a range of providers who we could see that were extremely good at adopting innovation, and we spoke to them about what is it that makes them particularly good at adopting innovation. And one of the things that differentiated the hospitals that were very good at it from the hospitals that were less good at it was actually they were not just focused on creating new inventions and new innovations and problem solving, because we saw that widespread across the board. It was where they could actively look for innovations and solutions in other areas. So from other providers, they weren't just concerned about sort of promoting and progressing their own technologies. Secondly, when they had those, they had board level support, so somebody where they could actually take that to, and that person or that group was empowered by the board to actually to implement those and to plug into the clinical teams and the clinical networks that were required, and to link that into the contractual changes in order to make sure that was transacted smoothly.
Thanks, Matt. Tim, then David, then Ara.
Thank you very much. I just wanted to comment that from my side of the Atlantic, the efforts that you are putting in are really remarkable. The fact that on my side of the Atlantic, we allow technology adoption to be a really completely haphazard process. And the fact that you have an organized effort as detailed through this excellent paper, I found insightful, remarkable, and frankly, I'm envious. So kudos to you and your team, and and for the whole the effort to move these technologies. On my side of the Atlantic, we call it the fourth translational block, is the academic term for this, and it often is the difference between a technology getting to help patients and not, and having an organized effort to address the fourth transitional block is a terrific. So thank you.
David, I think you're on mute, so I'm guessing lip reading that you were. Yeah. So Matthew, great stuff. Thank you. It's really just a word of caution on artificial intelligence, and I'm sure it's well plugged in. But it has incredible power. Of course, it covers many different spectrums of activity. But when thinking about awarding, I would have a screen that says, can people demonstrate to you how they are ensuring there is no bias in their work? Because there is an increasing degree of evidence, I think, that there is implicit bias based on the fact of the data or the algorithm, etc., that they're sort of using. And I just I don't know what we're thinking about that, but it's quite prevalent and can be really quite profound.
Thanks, David. Ara, did you have your hand was up a minute ago?
Yeah, just to finish off, to thank Matt for a remarkable job he's done. He just pointed on one thing. The most important part of this, after fixing all the national issues, is patients, is patient empowerment, is really bringing patients with us. In my own personal experience, most of my services and what I provide has changed because of a patient pull. And that's absolutely, and obviously it has to be evidence-based. So just to finish off, I just want to say thanks to NHS England, all the executives, Simon and many others who've really been, Julian, who looks at the prices of these things and the cost of these things. They've been exceptionally generous in their support in making this, to get this to where it is. But this has been a chronic problem in the past, and we've managed to get through some of these difficulties thanks to you all.
I think it's worth saying as well, though, Ara, and actually really coming back on Tim's point, that compared to the US, it may be more haphazard in the US, but the US does adopt innovation to a much greater degree and much quicker than the UK does. And I think what the AAC done has started to rectify some of that. But we have actually got a long way to go. It is incredibly difficult to get adoption taken up at speed and at scale within the NHS. So I think, Matt, I think you're doing a fabulous job. You know that. I don't think we would have got the Grail thing done without your support. The fact that you're working so closely with Novartis on the inclisiran adoption in the UK, the work you're now doing on polygenic risk scores and clinical trials is all, fantastic stuff. So, all power to your elbow. And I think, Ara, you've given the AAC a huge lift by working so closely with it. So thanks to you as well. Emily, did you want to have a final, and you've joined this, did you want to have a final word on this, Emily?
I would just add thanks to the team, and I think particularly to also, as Ara said, to Julian's team, because some of the the complexities of evaluating, ensuring continuity of funding so that we don't interrupt patient care, to Ara's point, with particularly some of the devices pieces, has been incredibly important. So massive joint effort, and of course working across government as well, not just with NHS England. So to thank everybody for the support, and Matt for his and his team's really impressive work.
Good. Well, Matt, thank you very much for joining us. Thank you. The next item is integrated care systems, which Simon is going to introduce. I think actually, Simon, you sort of introduced this when you first wrote the 5-year forward view, which is 7 years ago. So that's when you started testing out the concept of integrated care systems. So would you like to introduce this paper? You're on mute, Simon.
Thank you, David. I will do briefly that. I'm going to hand over to Amanda. I think, as you say, the first point to note is that we've been on this journey for some while. So this is not a blank sheet of paper. This is not a tabula rasa. This is essentially setting out what the next steps for April 2021 needs to look like, with or without legislation. However, on the legislative point, it's worth also saying that you recall that we had widely consulted on our proposals previously. So again, this is not starting from scratch. These are just a couple of sort of evolutionary updates to those proposals that have been through the NHS Assembly, have got, I think, a wide support across the service and with our partners. But let me hand over to Amanda, and then perhaps following discussion, we can come back to some of the next steps on the legislative point.
And I think Bill McCarthy has joined us on this call, Amanda, as well. You might like to introduce him.
Thank you, Simon and David. Yes, I've got Bill McCarthy, who is the Regional Director for the North West, is with us for this part of the discussion. Bill has led an awful lot of the work on the development of this policy and been involved in some of the very deep engagement that's gone on over the past few weeks and months to get us to this point. So be delighted, David, if I just say a few words, maybe to hand over to Bill just to add to what I'm saying, and of course to answer questions as well. So just to pick up on what Simon said by way of introduction, I think it's right that this proposal today is as much about next year as it is about potentially where we might be from April 22 onwards, because this does really reflect, I think, what we have consistently heard from colleagues across the NHS, local government, wider partners over the last weeks and months, which is that there is a real commitment to going further on the integrated care journey. And there is a call from, I think, our partners to us to make that easier. And some of what's contained in the document is really trying then to say, how do we then remove some of the barriers that exist at the moment, and how do we assist people to do in the main what they want to do anyway? Because I think this is the first point to make. The real point of all of this is four things. It is about an absolute commitment to improving population health and healthcare, tackling unequal outcomes and access, enhancing productivity and value for money. And I think something that's been writ large through the COVID experience, it is about helping the NHS to support the broader social and economic development, and the need to find a way of being able to organise ourselves around those priorities is the thing that is driving this work. So it starts with purpose. As I say, it's a deepening really of a next step of a journey that we've been on for some time, and it's about kind of removing barriers that enable us to take those steps. So specifically, what the document describes is a commitment, I think, now to saying we know that decisions taken closest to the communities that they affect are likely to lead to better outcomes. So that absolute importance of the neighbourhood, of the local community, and of organising services and empowering decision making at that level. Secondly, the collaboration between partners at place, so that's across health and all aspects of health, social care, wider local government, voluntary sector, patients themselves, of course, at place level, again, is where we see the greatest opportunity to make the biggest impact on the health and outcomes of the population. And we know that about 80% of healthcare takes place at that local place level. So the ability now to start to think about how do we effectively devolve funding to that level? How do we set up governance structures that binds in partners to be able to work effectively at that level, building on the journey that we've been on so far as part of what this document talks to. But then there is a third aspect, which is a broader collaboration between providers, some of which will need to take place at a much wider geographical level, because if we want to start to get into being able to do things like approach recovery with a real eye to equalities, if we want to be able to really deploy mutual aid in the way we've done this year as much more part of our business as usual operating, if we want to be able to start getting into specialist services redesign and specialist services provision, then at wider geographical basis will make much more sense for that. So what we've said in the document is ICSs really need to be able to be organised to do a number of things. They need to be able to do the distribution of financial resources, it includes the improvement and transformation resource, have the levers around operational delivery, and that includes, of course, workforce planning, commissioning, development, emergency planning and response, and crucially, the digital and data architecture to enable them to do that. So if that's what we're asking of ICSs as we go forward, what needs to be true? So what we've said in this document, and again, when I say we, I mean, this has really been co-created so deeply with partners across the system that it feels like it's slightly odd saying we in some ways as we describe it. But what we have said in this document is there is a very specific set here of opportunities for providers. So there's an opportunity here to have a very clear seat at the table, be part of that decision making at ICS level, but then to take responsibility in partnership for delivering some of those outcomes and have the levers and the responsibility to do so, which we know that many places have self-organised to do despite some of the barriers, but this allows hopefully this to be kind of locked in now as a way of working for next year. So higher quality, more sustainable services and providers at the table to make those decisions alongside other partners. So it is a change. It will be a change for some providers, but in the main, a change that we know that our provider colleagues are looking for the opportunity to contribute in this way. So the other big kind of offer here, I suppose, is really to local government, where what we're saying is the whole point, and Simon wrote it right back when we did the long-term plan and before that, in the 5-year forward view, the whole point of this is if we are going to be able to deliver the kind of improvements to population health that this is all about, then we've got to do it in partnership. And there's a very, very obvious opportunity, not just at ICS level, but particularly at place level, to bring that to life. And we've seen that across this year in the response to COVID. So each area is different, but what we've tried to do in this document is say, we encourage flexibility, but within a framework. And the framework is the thing that allows us to then give confidence, particularly to local government partners, about what that seat at the table looks like and how they will play that critical partnership role with the NHS in delivering that population health ambition and that wider set of objectives around the social and economic recovery of the country. So I won't go through every single bit of this. I could, but I won't. Instead, I think I'd just like to draw out a couple of things, if I may, because the third group of people who will read this and I think see potentially something very exciting in it, but also, let's be honest, something that's also potentially daunting are our commissioning colleagues, because what we're describing in here is a very clear and important role for commissioning, but an evolution from where we are now. So into something that's much more about strategic commissioning at ICS level, about helping really drive some of those changes, improvements in pathways at place level, and something that gets right alongside the providers so that we're driving again change that's for the benefit of population. But we're describing that in a way which I think means that although that highly values the role of commissioning colleagues, that will by necessity look a little different to where we are at the moment. It will be that evolutionary step on the journey. So just to say, the document sets it out, I hope, reasonably clearly, but there are certain things that we've described in here that kind of are I think, necessary, but on their own insufficient, but in totality hopefully add up to the underpinning things that need to be true to allow the steps to be taken next year. It is about a financial framework that supports this way of working. It is crucially about this clarity on digital and data and the way that that needs to come together at system level. It's a recognition that regulation also needs to change, and the way that we describe our single oversight framework needs to reflect what it means to be an individual organisation playing a role as now in the system, but also what it means to be an effective player in partnership with other system colleagues. It talks about, as I say, the way commissioning will change in the way that I've just said, and a bit about the key principles that will need to guide us as we think about the next steps also in relation to specialist commissioning. And then finally, as Simon says, it does set out 2 different options around legislation Ian might want to talk a bit more about this, who's helped shape the thinking on this over the last, again, few months. Moves on from where we were with legislation before, where we were talking, I mean, much of it, of course, the same and a very clear build on it, but does take us forward to talking about two options, one of which is a statutory committee model, the other a statutory corporate NHS body. Describes in next steps, I think, a very clear and, from my point of view, a really important commitment to saying, given that this is something which feels like it's a very bottom-up driven set of changes, we need, in the way that we manage next steps, if we do end up really adopting this and going for it quickly, to think really carefully about how we support our people through this. So minimal disruption model, a real commitment to that continued employment promise for anyone whose roles are disrupted through this process. And that is really, I think, an important principle for us to hold on to through this, because I'm conscious that while for most people, I hope, who read this, they will see something in it to get very excited about, we also need to recognise that change is difficult and that we need to support people through that, because not everybody will be perhaps quite as enthusiastic. So really important that this is an engagement document. We're looking for feedback. We're seeking now views, not just from the NHS, but of course from a much wider set of stakeholders and broader partners over the next 6 weeks, to help us really then hone down and shape not just our recommendations to government from a legislation point of view, but also to develop the sort of further thinking, the detail behind what we do next year to really get some momentum behind this and make a difference on the ground, because that's what it's all about. So I'll stop there, but Ian, I know, will want to come in and in fact has his hand up, but David, Bill might want to add as well.
Just before we bring Ian in, Bill is here as well, Amanda. I'd just like to get your reflections on this as well, Bill. You've seen, we've been talking about integrated care for many, many years, and you've been sort of, involved in the policy for a long, long time. What are your reflections on the proposals before us today?
Thanks, David. I shan't add hugely to what Amanda said. I think that was very clear, but perhaps just 3 points, David. First one is about the process. I think I can't stress too highly, really, that this isn't a bit of blue sky thinking from a remote body somewhere. This really is our understanding of how the best of the NHS and partners locally have responded to two very significant events. One, the long-term plan and the challenge that was set out in that about integration, about working around the needs of patients, but then also the COVID experience over the past few months. What's in here is drawing from that real experience of where I think our leading systems have managed through in a way which has achieved the 4 objectives that Amanda set out. Second point, I think really important here is clinical leadership will be and needs to be written right the way through these new arrangements. We were talking before finalising the document with colleagues in the Royal Colleges, as well as with the GP leadership. And I think there is a real appetite to be fully engaged at place, in the provider collaboratives, but also at the ICS level. And I think it's really important we reinforce that message and make sure the way this is implemented it is, by embracing that real strength that we were referring to earlier, actually, that clinical leadership will give to the way we can better shape services to serve our patients. And I think the final point I wanted to make is perhaps a little bit parochial, because it's very important to people in the Northwest, if I may, David, and it's about inequalities. And I think COVID has shone really quite a harsh light on some of the underlying inequalities in health status and in opportunity, which we've kind of known have been there, and which have been, I think, quite seriously exposed through COVID. I'm convinced from speaking to colleagues locally, including local government colleagues, as well as the voluntary sector and our own people, that this approach to really deep partnership at the level of place, a real collective understanding of the highest risks, of full participation of the NHS in the social and economic development, as well as in meeting the needs of those most vulnerable, will be at the heart of tackling inequalities into the future, as well as the opportunity that the provider collaboratives on a bigger scale will really give to make sure that access to services doesn't just depend on which hospital you happen to live closest to. We can organise that better, and I think we can do better on the back of this to tackle those inequalities that I think is our obligation.
Thanks very much, Bill. Ian.
Thank you, David. I just wanted to make 2 points about legislation. So the first builds on Simon and Amanda's points around this document being what ICSs and systems can get on with and do in advance of legislation. And I think what marks it out from previous journeys is the extent to which we're seeking to design almost a legislative commencement moment to have the least possible practical import. This is not about a lot of change happening at the date of royal assent and commencement. It is about facilitating change to continue to happen as it has been happening now and in advance of that moment, whenever that is, and indeed thereafter. And I think that does mark a fundamental difference in approach. I'm not just looking back to 2012 or 2013, actually, but previous changes that have occurred in the preceding decades. And the second point I wanted to highlight is Amanda's point around process. Last October, we discussed as a board a really important set of proposals that had been shaped by people in the NHS. We had a massive engagement process with nearly 200,000 responses setting out our proposals and recommendations to government, and they were genuinely shaped through a consensus building process. And the reason why we have come back with these adapted proposals for legislative change, specifically in relation to ICSs, is we had been hearing, thanks to the further years worth of work in integrated systems and also the experience of COVID, a degree of disquiet in the NHS and our partners that what we proposed in relation to legislative support for ICSs may have been too light and doesn't meet their full ambition. And it is in response to that that we have worked up these two specific options. And in exactly the same way that we engaged our partners in a full and transparent and consensual process, that's why today marks the launch of an engagement process publicly. And we commit in exactly the same way to listen really hard to what people are saying and to come back with our final proposals, revised or otherwise, and we will publicly set out our own independent advice to government to help shape the drafting of any forthcoming bill.
Thank you very much, Ian, for that. Tim and then David Bean.
Thank you, David. I'd like to just if you asked for your indulgence for a moment to state what it means to be a provider inside an integrated system and how that affects patient care And I just want to emphasize, as a primary care doctor who has practiced basically in solo practice and then practiced through the transition to an integrated delivery system, what I see for our patients is remarkable. And I want to highlight just a few of the things that are benefits to our patients. I first want to say that for the patient with a minor acute episode, really this is about convenience, access, and improved experience. But the main benefits actually accrue to our patients who have chronic illness. And complex chronic illness and the way our systems, when they are not coordinated and integrated, force the patients to be the navigator of their own care delivery, is the burden we put on our patients, particularly those with complex chronic illness, is really, it's hard to imagine unless you've experienced it. Integrated delivery systems have the really big benefit for our patients of actually coordinating that care for them because of the very nature of integration. I think the term on your side of the pond that's often used is joined up care. So I've experienced that as a provider, a primary care provider, and I actually can't imagine going back to a world in which I wasn't able to provide that kind of wraparound care to the patients that I care for. And I am really looking forward to helping in any way I can the push to do this within the National Health Service. So thank you.
Thanks very much, Tim. David Bean.
Thanks, David. I think I might my point might build on the one that Tim's just made. I think this is a significant development, and I absolutely take the point that this is part of an evolutionary process of change. But I just wonder whether in the document itself and the explanation, whether the voice and the interest of those people who are using services has been given enough prominence. I hope that builds on the point that Tim's made about where the advantages are from working in this way for people who are using services and their carers. And as I say, I just reflect whether we've said enough about what how the voice of people will be captured and their interests will be captured in the way forward. Thank you.
Thank you, David. Amanda, I might ask you just to sort of respond to David and Tim's points there, but in particular, just in the paper, there is a reference to putting both digital and data transformation, but also putting the citizen at the centre of their care, which I think really goes to the heart of what Tim and David are getting at. Would you like to sort of just reflect on that?
Yes, thank you. Look, thank you for that really helpful feedback, and to my colleagues for building on and amplifying some of the things that I said by way of introduction. So I think it's in a sense the opportunity, the great opportunity of having this out there as an engagement document rather than, as Ian says, as a sort of final document, is the opportunity to really hear back some of those sorts of really helpful challenges, but also areas where no doubt we need to do more in a whole range of areas. And I do wonder whether the fact that you've just pointed out, David, that where we talk about person-centered care is in digital data, we might be doing ourselves a bit of a disservice by putting it there, because actually what it's about is using digital and data, of course, as a way of giving people different kind of control over their interaction with healthcare, rather than that's something that we talked about earlier, rather than the more traditional models we've got at the moment. But but actually, of course, it's so much more than that. And when we talk about this, I've talked to colleagues about this over the last few weeks and months. Actually, it is the person-centered care that people get really excited about, that and population health management. Those are the two things that when you start talking about it, people go, well, that's exactly what we want to be doing. And so what I think we need to do is just probably check ourselves, don't we, that that's written into all of these different aspects of policy and practice that we're now developing over the course of 21-22, so that it doesn't feel like it's something that we've put in just in one box. So, for example, I'm aware we've said Health Watch need to be round the table as part of the governance arrangements at place, and we've talked about some of the governance arrangements, I think, explicitly with a view to the sort of patient voice being very much an expected part of that. But let's take that challenge away and see whether that's something we can write up and go further with, because it's certainly at the heart of what this whole endeavour is about.
David, might I come in on that specific point around personalised care?
Who is that? Ian?
That's me. Yeah.
Ian, yes, do. Yes, please.
Great. Look, and just picking up, Amanda, on your response, and David, your question, which I think is an incredibly important question. I think we probably haven't done justice in the document to the fantastic work that we're driving through James Sanderson's group on personalised care, writ large in the long-term plan. In the very first chapter is the implementation of the NHS model, the comprehensive NHS model of personalised care. We have been, it's got a number of different core components, and we've been continuing to drive that throughout the pandemic. So a huge focus on shared decision making, on the rollout of personalised care and support plans for many of our most vulnerable patients, and patient empowerment, including focusing on their wider non-healthcare needs. So the huge expansion of social prescribing and the connection through to other community services, and personal health budgets. And we had a goal set by the government in the mandate to try and achieve at least between 50 and 100,000 personal health budgets by 2021. We exceeded that goal actually by the end of the last year. And I think there's a lot more that we're continuing to do in exactly this space that goes well beyond digital.
Thank you, Ian. I think we're sort of coming to the end of this discussion on this topic. Simon, I think you're going to have a final word on this.
Thank you, David. Well, it was just on the legislative point, really underlining the discussion that we've been having and the evolutionary nature of what's proposed here. And I came across this rather good quote, which I think characterises the approach we're taking. It's a quote from the patron saint of the National Health Service, Aneurin Bevan, and he said that no legislation, however wisely conceived and how efficiently embodied in an Act of Parliament, can ever give the public a great health service unless the people who administer it want to do it and are enthusiastic in doing it. He went on to say, that is the progress of legislation in this country. It starts off by voluntary effort. It starts off by empirical experiment. It starts by improvisation. It establishes itself by merit. And ultimately, at some stage or other, the state steps in and makes what was started by voluntary action and experiment a universal service. And that is what we're proposing with the integrated care systems.
Simon, you might like to send that quote to Andrew Lansley and see what he makes of it in that case. Anyway, that's a very good quote, and I think that really encapsulates exactly what we're on about at the moment with integrated care systems, absolutely down to a T. So that's a very good place to end it on. Thank you very much for that, Amanda, Bill, Ian, everyone who's been involved in this. Thank you very much. I think we're in a very good place on this. So moving on to the next item, Prerna.
Hello, David.
And I think is Claire Murdoch here as well.
Hello, yes, good afternoon.
Oh, hi, Claire. Prerna, over to you.
Thank you very much. Thanks for the time and the focus on staff health and well-being. I first want to start by acknowledging the extraordinary work that NHS staff have done, well, ever since 9/11 and the quote that Simon just shared, but actually especially in the last 7-8 months to respond to the pandemic. Not just NHS staff, but all healthcare, social care, and all essential workers. So a huge thank you and an acknowledgement. And the conversation about health and well-being support to staff is very much rooted in the challenge that staff are facing in providing care. And I wanted to share some practical steps that we've taken. And then my colleague Claire is going to talk about the treatment assessment aspects of the offer that we have, that we're building. So within 3 weeks of the pandemic and the emergency being declared, we worked very quickly on a health and wellbeing offer at the national level to augment what were really, really supportive offers at local levels as well, by local employers, by local businesses, by local voluntary sector organizations. So on the 7th of April, we launched a national offer which was available to all 1.3 million NHS staff, and some aspects of that offer were also available to social care staff. The parts where they weren't available to social care was because of funding constraints and the nature of the service that we were providing. So first, also a shout out to our partners. This health and wellbeing offer was made possible in many cases because the entire country got behind NHS staff. So this was at local level, offers of transport, offers of food, free, food and drink. So supermarkets who had packages made up for NHS staff that placed vans in car parks of providers so that workers coming off shifts would have access to groceries. So just a whole host of local offers. And at the same time, in the spirit of do once, a small number of things that should be done nationally, we convened an expert reference group made up of people who have been in emergencies before, who have worked with the WHO, who have been in complex emergencies and incidents in the UK, who advised us the kind of support that staff would need. This expert reference group has helped us have an evidence-based approach. We continue to work with them, actually. And as the nature of the pandemic has changed and our response have changed, we have also built on that offer with their advice and support. So it is a model which is based on the 3 stages of prepare, active, and recover. Those are the 3 stages of an emergency response. And actually, there wasn't a lot of time for prepare. And we are not yet in recover. So all of our support is focused on the active phase. The model is based on an end-to-end pathway. They've advised us very clearly not to over-medicalize the kind of support we should give staff. It's focused on prevention and self-help as the majority of the support. And I'll just detail a few things that we're doing on that end. And then a small focused amount of support on those who need more medical intervention. And Claire will speak about the mental health aspects of that. So the second aspect is that people get their support from teams. Resilience resides in teams. And that's trademark Claire Murdoch, so must give her credit for that concept. And what we have then done is to make sure that we have tools and resources available for teams to be able to support each other. From feedback, we know that 2 things that we have introduced for teams have had the maximum impact in terms of resilience. One is what we call the 10-minute pause. I mean, not we, but it's called the 10-minute pause, where we are encouraging teams, especially after stressful incidents during a busy shift, to take that 10-minute pause where someone can step out and center themselves and come back in. It helped people to have permission to do that, and we've really been pushing this 10-minute pause. The second is the Leaving Well checklist, where there is a way that you can leave a shift where you can go home and recover and then be able to come back and provide compassionate care the next day. These are the 2 key interventions at a team level. On the self-help level, we have 153,000 people who are using the mental health apps that are available free. And again, shout out to partners who have made this possible. What we've also done is inbuilt feedback throughout this whole process. So actually, when people use an app, they provide feedback, and we, of course, in an anonymized way, get that feedback and can in real time make changes and augment our offer. So for instance, mental health apps are showing that it's actually helping people to sleep better than before, actually even before COVID, because we have to remember that health and well-being was an area of focus, but not as much, and an area of challenge before COVID as well. And one of the big shifts in our culture in the last few months in the NHS has been the enhanced focus on staff health and well-being, which is absolutely right. So we're having a constant dialogue with staff, a few enhancements to the health and well-being offer as a result of their feedback. One was that our colleagues from the Philippines, who had tragically a high loss of their colleagues, relatively speaking, asked us for a bespoke bereavement service in Tagalog, and we made that available along with Hospice UK. We had feedback that people were suffering from secondary stressors. So what they're bringing to work is, of course, their whole self. And as we have impact on the economy, we have people who are concerned about family members, jobs and financial situations. So we have partnered with Money Advice program, and we provide financial advice that people are taking up. This started on the 1st of October. We are also making sure that we're normalizing, in fact, supporting help-seeking behavior, because research shows that healthcare staff and social care staff are amongst the last to seek help for themselves. So although people are doing extraordinary work, our clinical reference group has advised that we shouldn't label it as heroic and heroes, because actually that keeps people from seeking help. So we're being quite, well, hopefully being quite thoughtful about how we're engaging and communicating, not only that the offer is there, but actually how to access and why to access. We have also made, like the Filipino support, other support available to BAME staff. We have been convening a national BAME staff network conversation that I have convened since April, where we ask directly what staff need, especially as we see the disproportionate impact of COVID. So actually the risk assessments, which was a staff safety and health and well-being intervention, came from that group. We are also working with faith groups on health and well-being, and BAME staff especially had said that they get a lot of the, pre-COVID, used to get a lot of their support from places of worship and faith groups. And with that aspect not available, we have worked with faith groups to connect directly to our staff in COVID-friendly ways. I wanted to draw the board's attention in the paper to some real quotes which are on page 4, and it's from real people, and it gives you a flavor of how people have experienced the health and well-being offer. I think before I hand over to Claire, I would like to say, as Amanda said right at the beginning, this shift in health and well-being support must remain one of the enduring positive changes out of COVID. We really can't go back on this because we know that some of the challenges were there before COVID as well. And we were saying in our team, one of our learnings is that what I think in many other parts of the service, what would have taken probably 3 years to achieve was possible in a matter of weeks, and that we must hang on to and build on. Our experts say that the biggest thing that will help people recover is the sense of hope. So in leadership messages, in engagements with managers with their teams, we must remind people that the pandemic will end one day and soon, and that the positive changes that we've seen, whether it's flexible working, increased use of technology, etc., and health and well-being, are here to stay. So that's the advice from the expert group for leaders. And then there's been increased investment of 15 million for all regions to have health and well-being hubs, mental health and well-being hubs, and then enhanced occupational health and well-being services in 14 systems being piloted, that I wanted to hand over to Claire. Thank you.
Yes, thank you very much for that. Just by way of introduction, I'm the National Director for Mental Health in England. I'm also the Trust Chief Executive. We have 7,000 staff colleagues in my trust, and I've worked in the NHS for 37 years. And I have to say, I've never been more proud to be part of the NHS. I've never seen more determination to do the right thing by patients and each other. And I would just like to say, I think we have to resist, as we think about how we support our staff through this, we have to resist thinking that our staff are on their knees or in despair. And I think that when I visit either different places across the country or across my own organisation, I hear the most extraordinary stories of how well-trained, values-driven, hard-working colleagues are actually, in many cases, quite upbeat about what they're doing and pleased to share what they're doing. I think Prerna's absolutely right that there's a determination to leave legacy out of what has undoubtedly also been a really tough time, and for some teams and in some places it's been extraordinarily tough, but there's a determination to leave legacy. And I think some of what we've learned has been that staff have felt in many parts of the country heard, given more license to act, more freedoms to move quickly, to do the right thing. They have appreciated the additional money currently. For example, I know there was a big cheer in many parts of my sector but beyond about the additional money that we will get to help us through winter and into next year, because that drives very practical supports, whether that's more staff, better environments and so on and so forth. So I think that there's quite a lot to be, and it's to link to Prerna's point really, hopeful about. Never complacent, but absolutely always hopeful. I think some of the other things that we could be hopeful about is I understand that more than 10,000 people have already volunteered to come to the NHS and help with the vaccination effort. I understand we've got more people coming forward, for example, for nurse recruitment than ever before. And thank you very much to Prerna, our chief nurse and others, Health Education England, for driving that. There are, because having enough staff is a critical part actually of staff morale and staff welfare. When you're working in teams where you have enough staff, you know you can take your rest days, you know you can take your holiday. And we've certainly been talking about things like making sure people take their leave, even now, even though they can't jet off to the Caribbean or Spain at the moment, having their breaks, having downtime away from the keyboard, away from frontline clinical work is critical through this period. So we need to do those practical things as well. But thank you very much to Simon, Amanda and everyone who has, Julian, who's got us that additional very practical investment. Prerna's quite right, resilience resides within teams, and one of the things I've heard from many teams across this last period that we have to build on is they felt much more free to act, to do the right thing, and they've never had so many conversations with their executive boards, chief executives, medical directors and nurse directors. Why? Because we've been digitally enabled to reach into the corners of our organisations. Anyway, so I think there is much to be hopeful about, but of course never complacent that this is going to be a tough winter. But our staff colleagues never cease to amaze me. There's also quite a lot of fun out there on occasion as well, I think, and I think we have to value that too and create time for that as well. But to come to more or a very serious point, we know that for a small number of our staff, in addition to everything that we're doing to support them, a small number will experience anxiety, depression or other mental health problems to a point where they are suffering. What we're wanting to do with this additional £15 million that we have is to establish these hubs across staff wellbeing hubs across all 44 of our STP, ICS or local systems. Many of them are already in play and were during wave one, so we're building on learning from that. And the key aim is to make sure that we can rapidly assess and treat those people who are referred either by themselves or through occupational health or some other route. That's one element. A second element is for those staff who have particularly complex needs, we are building a national referral route to get them more bespoke treatment. And a third element, which the chief nurse is leading, is training, psychological wellbeing training for critical care staff, because actually you can build that into, you absolutely can, and the evidence shows that, and there's learning also from colleagues in the military and other sectors, that you can train yourself to build that resilience into how teams work, how you spot stress in each other. So there are three particular components to the assessment treatment, specialist treatment at a national level, and then also the psychological well-being and training. So of course I'm delighted that we're building that particular bespoke mental health offer into the overall wellbeing offer. But I would just like to end this little bit, if I might, where I started, which is to say I see a huge amount of resilience, professionalism, hard work right across the NHS, even if we sit here now.
Thanks very much, Claire and Prerna. Well,
Thank you, David. Just a comment very quickly. Prerna, I think that one of the issues is that whilst we're sort of still fighting and hopefully finishing this battle war campaign, what do you want to call it, on COVID, all these things stay on the agenda, and it's very important, and people get focused on it. But let's be honest, the further we move away from what was the crisis, the less and less focus gets put on it. I would really encourage you to find a way of ensuring this stays on the agenda and the board is fully sighted on it. So whether it's biannual reports or focus, that's the first thing. The second thing is, I really think that given what the NHS has done in terms of this pandemic, we should be the exemplar for what good looks like across the UK, England, definitely the UK, in this activity, given the numbers of staff we've got, given what they've gone through. So rather than following, we should be leading. So those are my two challenges for you.
Thank you, Will. Any other observations or questions for Prerna or Claire? Claire, could you just give us sort of insight on what it's like in your trust at the moment, and how you're coping, whether you're seeing a lot more demand in your trust, and not just from a staff perspective, but from an overall perspective?
Yes, we're busy, of course, and we're happily seeing a recovery of restoration of the trajectories, referrals. We're seeing more patients. Some of the stuff that tailed off during, some of the referrals that tailed off during wave one are picking up a pace. So we know we're really busy. Certainly the urgent emergency care pathways, both in my own trust and elsewhere in mental health, are very busy, which is why we're so delighted to have had the additional 50 million nationally, not all for my trust, that we're rolling out now to help support that pathway. I think there's a big determination and largely quite an optimism overall that we can get through this. I think the vaccine on the horizon helps. I think we've got opportunity to further build on the innovation that we discovered during wave one. So some of the things that we just did during wave one, like we just did break down more of the barriers between physical and mental health care. So if the mental health unit needed the district nurses or community nurses to go in and further advise on physical health care, we just did it. We didn't look at the contract and who could do what. If we needed to support care home staff, we just went in and did it, across primary care. So people are tired. We're taking really seriously, as I think every chief executive in the trust is. Are people getting breaks? What are their rotas like? Are we making sure they get the downtime? We're focusing on recruitment. So we've got lots of intent. One of the bits of feedback in my own trust, which resonates right across the country, that was very positive from wave one, was people enjoyed having more regular weekly or bi-weekly briefings over digital applications. They felt it collapsed the tiers of the organisation, and that they were able to input their ideas, ask their questions to top teams. It really helped the top teams because you had an absolute finger on the pulse with what it's like. I was really pleased Prerna mentioned overseas staff. Of course, we're keen to see staff who are used to going overseas to visit families, who haven't been able to for a long time now. We're already thinking about holidays as we start to recover and how we smooth workforce across that period, and we're doing that with staff and staff side. I think these things are happening across the country in every trust and across healthcare. But we're working really hard, no doubt about it, but there's a strong sense of purpose, and the additional workforce, the additional funding really help.
Good. Thanks very much, Claire. Steve Powers, and then Prana. I'll come to Prana, yeah. Steve.
Well, it was really just to say how welcome this is. I think Ruth referred to, the huge amount of work that staff are doing earlier on in the board meeting, and I certainly hear the same from my colleagues in doctor leadership roles and medical leadership roles. And it's been an incredibly challenging year. It's going to be an incredibly challenging winter. But as you said, Prana, this is not just for this winter. This needs to be for years ahead and years to come. So I just want to say thank you for all the hard work you and the team are putting in, and how welcome this is across the system.
Thanks, Steve. So Prana, last word from you before we wrap up.
Thank you, and thanks for the comments. I've seen Wal had to drop out, but I was actually going to tell him that the team, my team who worked on the health and well-being, has just won an award in the last 5 minutes. It's been announced for the Health and Wellbeing Initiative of the Year. And this is a national level award by Personnel Today, which looks at people practices. So I will send an email to Wal that actually we are leading in some ways and being recognized for that. But I think it's important that the board, as you've said, holds us accountable for continuing with this effort. We want our staff to feel treasured. We want the work they do to continue to be treasured, and this is very much a part of our recognition of the work that they do. Thanks very much.
Well, Prana, thank you for that, and congratulations on the award. And that's, as Wal said, we should have this as a regular part of the board agenda going forwards, whether it's quarterly or however we do it. We should definitely. So we're all kept up to date with this. So thank you both very much indeed. That's terrific. I think the last item is just a formality, which is just the use of the NHS seal, which I think we just note, Sophia, don't we, for the purpose of this meeting? In which case, I think, unless there's any other business, I think we'll bring it to a close. Thank you all very much. Thank you.
Thank you.